I would like to thank the organizing committee and my wonderful friends for inviting me here. I have experience from the UK, which I hope to share with you. All my intention today is just to stimulate the thinking and the discussion about what we can do with urgent care. If our patients go to the accident emergency department or ER or ED, whatever you call it, what happens? Our patients with mental health have 5 more times to end up in ED department. But when they end up in the emergency department, what happens to them? Number of things. One, they get very bad experience because most of the doctors and the nurses are not trained in mental health. They are trained to deal with accidents, with heart attacks, with strokes. So the experience we know from research, they see our patients as waste of their time. They shouldn't be there. That impacts negative on the patients. But our patients go there because they have needs. I led a liaison psychiatry team, which won prizes in the UK. And all my intention is to move the patients quickly when they come to the ED department. Just to discover I was missing the target. I will show you now. This is what is happening in the UK in terms of mental health crisis. Patients end up in the ED department with suicide or psychosis or severe depression. If you look at the first graph, it has been increasing by 12% every year. But if you go to the second one, you see that prediction, it will go up by 12% every year. About 1,500 new cases every month in Birmingham and Solihull, only in one city. Now, with the pandemic, we get 2,000 new cases of mental health crisis every month in one city. Can we cope with that? This is why patients come to the ED. But as you have already covered what happens with the COVID, all what I showed you was before the COVID. But with the COVID, they're going to happen what we call the tsunami of mental health. So these systematic reviews shows there is about 25% increase with the COVID in terms of prevalence of mental health. In terms of anxiety, we're expecting like 3,000 new cases in every 100,000 population. Depression, we're talking about 5,000 new cases every 100,000. I'm just trying to give you an idea, which you are already aware of the pressure we're going to face looking after patients with mental illness. This is another study about the impact of the COVID, a comparison between the UK and Germany. I can see there is a good syndicate of Canadian academics and French people. I don't know whether Germans and the British are here, but this is a comparison between the British and the German. Again, increased by 25%, but it looks like the German are a bit tougher than the British. So there is the British complain more than the German. I don't know which way you want to put it. Not only that, this is a study here from the Emirates. A very interesting study, which I was very pleased with the survey we have seen earlier on. But again, the same thing, 25% increase in mental health needs. There is 30+ increase in work pressure and home pressure. I know we don't have much of time to talk about this, but all of us are aware that domestic violence all around the world has increased with the COVID, with the lockdown. I don't think this is for our discussion today, but the point is increased pressure on urgent case, on mental health crisis. How can we cope with this? The whole world is talking about tsunami of mental health. The last time I was leading the mental health crisis, the call was about preparing for a mental health tsunami, where you have overload of mental health issues in the ED department and psychiatric services. Can we cope with this? Hold on to this kind of question, and let me show you something interesting. Birmingham is the second biggest city in the UK. The population is about 1.2 million. So it's not huge, but it's a big city. And what do we have there? Look at the resources we have. We have 5 big general hospitals, about 3,500 acute beds, which are occupied every night. And in each hospital, we have huge, big liaison team working 24 hours, 7 days a week. Also, we have emergency rooms. We have a project that created called the street triage, where if a patient in the community agitated, a car will go that has a policeman with a paramedic and psychiatric nurse to behold the situation 24 hours, 7 days a week. We also have 111, which is a helpline they can call. We also have home treatment team, where the team can go to the patient. We have a complicated bed management to find a bed for them if they need it. We have Samaritan, which is a voluntary service. We have Mind, another voluntary service. We have social services working all the time. We have GPs, primary care physicians, 24 hours, 7 days a week. Is that enough for 1 million population? What do you think? In the middle of that, you get a patient who doesn't know what to do when they have mental health crisis. All these resources become very complicated and the care is still not good. So my point about the COVID, increasing the resources is not the solution for the tsunami of mental health we're expecting. The solution I'm going to show you, hopefully, in technology. The problem is we all use electronic records. We all do research. We all have computers and all these kind of things. But when you look at big data, many cities, many services, even in the same city, the data don't link together. Computers don't talk with each other. I cannot access the records for many other areas. And it becomes very complicated. We work in cul-de-sac. So this is the first service we created, 111. Just a very simple phone line. People can call at any time, 24 hours, 7 days a week. And what is the effect of the helpline? If you look at the figures in front of you, you see here, these are the causes why people called. And this is the study. We looked in the evaluation of the service. So most of the referrals or the calls because of agitation, but also you get depression, people calling, you get suicidal thoughts, psychotic features. So this is why people call. And the call is dealt primarily by mental health nurse, and there's a doctor in the background. But look at this. Only 1.8% of those patients ended up in the ED department. And the rest either went to the community or the GPs, or they were guided through the website into self-care material. So this is one project. But I want to share with you another project. I was the director for that project. Birmingham is in the middle of the UK. And I want you to think about where you are in your location, or think about the Emirates and the different Emirates we have. Birmingham surrounded by 4 other big cities. Each one of them is completely separate, have lots of resources, exactly the same as we have in Birmingham. But when a patient in crisis, and mental health crisis, in the ED department, you cannot access the records from the other cities. When we need a bed, we cannot find it because the other cities have resources we are not aware of. So I was tasked by the Department of Health in the UK to look into a project we called Merit. And in that project, I wanted to link 5 counties together. The county is having more cities. In that project, I focused on 4 things. Can I link all the psychiatric beds together and can direct the patient where the beds are? Can I have access to read the patient records at any time from any city? Can I have a coordination if the patient lost? Can I have a website that the patient can log in and see what to do in the time of the crisis? Can I be reassured that all the staff we have in the 5 counties have the same training and the same standards? That was the project which you called the Merit Project. When you come to the beds, psychiatric beds, I mean, each county had different procedures, different policies. Have an empty bed, that doesn't mean it's available, because actually you need staff, you need to know that this is urgent, the level of observation, all these kind of things. So the first of all, I had to unify the policies between 5 counties and have lots of negotiation to convince people I'm not stealing the resources and give it to Birmingham. We are just sharing for the benefit of the patients. So we created a new electronic system that links all the beds together, and we had in our ED as a real-time screen showing where the beds are, whether that's for female or male, whether that's for one-to-one observation or simple observation. And then we created a daily call where even the people didn't come to the system who are expected, we can know what are the demands. With that, we significantly reduced the pressure on beds between the areas or transferring patients out of area. Sorry, I want to show you many things, so I'll speed up. The other one is, can I access records? Each county, as perhaps we have in Emirates or Canada or France, or each county had a complete different electronic system. And nobody would ever agree to change the electronic system to one electronic system. First of all, they paid a lot of money. Second, there's a bit of pride. I'm not going to go to your system, you come to my system, and all these kind of things. So working with the IT company, we created another electronic system that sits on the top of the 5 systems and glean the data we need for urgent care. With that, if you want to ask me later, we put all the safeguarding, confidentiality, tracking, auditing. But when I'm in crisis, in the ED and the patient from another county, I can look the up-to-date records in a very ethical way. Also, we created logging to website between the 5 counties where our patients at the time of crisis can find where the help is and what is offered for them and what they expect. We also created a training and a standard program for all the workforce in the 5 counties to make sure we have the same standards, but also about the workforce planning, that if I have a shortage in a staff, I can bring a staff from another county and I know they are exactly in the same standards and they will provide the same kind of care. So that is the Merit program, where we use the technology to improve the use of care. I'm going to share something more innovative with you in a second. The liaison team I created was called the RAID, or Rapid Assessment Interface Discharge. We got £2 million investment from the government, the UK government, to go further. Can I actually predict who is going to fall into mental health crisis and help them before they fall into mental health crisis? Can I do that? I'll tell you something. Predictive analytics is used to put the goods in the shopping center. They know what you're going to buy and what you need. In Laylat Sha'ban, they know what you need. In Christmas, they know what you need. And they put it free in the shop. The price of your flight ticket, they use predictive analytics. Can I use predictive analytics for that? Can I use technology to better use the resources of my team? So that is the pathway in the UK. Obviously, the patient be absolutely lost in the middle. And what we wanted to do is to create a new system where all the resources talk together and the patient is in the middle. Obviously, guess what? With a mobile phone, finding the resources and going to the right way. And we can communicate with the patient. I'll skip this for the sake of time. Right. For my team, I create a tool called Caddy. And guess what the Caddy can do? Every patient, once they come to the ED department and they're registered, I know there's a mental health patient. When did they come? How long they are waiting for? What do they need? A nurse or a doctor or a social worker? At the same time, I know the team available, how many nurses I have in the 5 hospitals, where they are, whether they are with the patient or they are free, whether they have the capability and the resources and the training to see this patient or not, and then you can guide your resources with your patient's needs. You can measure the flow all the time, and that measurement is real-time measurement. Not only that, it calculates the saving value, the value of your team in terms of money and beds. And if the patient needs a bed, electronically we link to the bed system, and the bed system know there's a patient that needs a bed in one of those 5 counties. You can access this from your mobile phone, from your computer, from all these kind of things. Let me, so this is the way we're going. There's a lot of technology. I'm not going to talk about for the sake of time, but the one I'm interested in is virtual reality. With Aston, we're looking into Aston University, we're looking into using virtual reality to train our elderly patients to prevent falls, to improve their activity of daily living. And this is something we're working on. But let me share this with you. This is the peak of my career. So this is my question to you. Can we use predictive analytics to predict who's going to fall into crisis? What do you think? Yes. So actually, we did a big study. If this is my last paper, I'm happy. Last week, this has been accepted in Nature. So that is what I'd say. Thank you, thank you, thank you. And what it shows, we did deep learning, artificial intelligence on our electronic records. We have 25,000 cases every year. Every case have thousands of entries. With deep learning, using learning models, we actually created a model that we use it in our electronic data to predict who can fall into mental health crisis. You can see the specificity and the sensitivity of the model, but to be practical, the model brings a lot of patients. So we created another ad on model where each team on 28 days basis will have the name of their patients who are predicted to fall into mental health crisis. So they can test that, they can contact them, they can help them, and you see the clinicians' acceptance was very high. So the roadmap for them, I think I'm on time. So this is the predictive analytics. There is some commercial sensitivity, which I'm not going to talk about, but you can guess after we have this predictive analytic model, what will be the next step? I'll leave that with you. I think there's a commercial sensitivity I'm not going to talk about. But the roadmap for us, with the tsunami of mental health coming, it is not to add more resources. It is a beast. It will swallow all the resources you put in. What we need is to have big data analysis, link the data together, have the ability to predict the crisis, deal with it using the word we mentioned many times today, using technology. Thank you so much.